Thank you. So I'll talk today on patient-reported outcome measures. Which ones really matter and how do we determine them? How do we decide on which outcomes and which measures? So the first thing I'd like to briefly focus on is what we mean by an outcome. So the definition in Donabedian's definition of quality is that an outcome is the change in a patient's current and future health status that can be attributed to preceding healthcare. So an outcome is a change that occurs in a patient's well-being that we can attribute to the healthcare that they have received. So we may focus in research on our inputs and our structures, the processes of care, the outputs of care, but it's essential if we really want to understand if we're making a difference that we focus on outcomes. I also want to orient us briefly to the idea of person-oriented care. And my colleague at the Institute of Human Virology, Carla Alexander, coined the phrase from the life of the virus to the life of the host. And where we try to focus in person-centered care is on a patient's physical problems, their emotional problems, their social problems, and their spiritual problems. And if we're able to do this using a valid, routinely used patient-reported outcome measure, then we have the opportunity to make sure that care is good quality, that it's accessible to patients, and that most importantly, it reflects what matters to them. So we do know that patient-reported outcomes are clinically important. What a patient can identify really matters in clinical management of people living with HIV. If we take the example of pain, we know that pain is a highly prevalent concern for people living with HIV. It has to be self-reported, and it's associated with a number of outcomes, including poorer quality of life, viral rebound, sexual risk-taking, poor adherence to treatment, treatment switching, and suicidal ideation. We've identified that in a number of cross-sectional studies. The work by Jesse Merlin in the US has also identified that among the HIV outpatient cohort, 25% had chronic pain, and that's associated with no-shows for at least one primary care visit. And chronic pain is associated with both no-shows and virologic failure. So these are outcomes that matter. So thinking more about the concept of person-centeredness for people living with HIV, we know from research that health-related quality of life for people living with HIV on treatment is poorer than the general population. That's from a UK study. And we know also that not only are people living with a high symptom burden, which may be physical, psychological, social, and spiritual, but there are emerging physical complications as people age with HIV. The contribution of physical and mental health to health-related quality of life has been identified as our current critical challenge in HIV medicine, and I think that's an ongoing challenge. And in terms of what people say is their experience of HIV outpatient care, outpatient attendees perceive that care doesn't address the issues of physical, mental, and social well-being that matter to them. So in terms of patient-reported outcome measures, what's the mechanism? What are we trying to achieve? Well, we know from the early work of Amy Justice in the USA that HIV practitioners often miss patients' needs and symptoms, especially non-physical ones. And she showed in research that an HIV clinician will detect around 1/3 of patients' concerns during a clinical assessment. We also know from the broader PROM literature that if you routinely use PROMs, it can help identify problems and concerns, helps improve outcomes for patients, and that's through team sharing and planning. So using routine data that's been collected to inform an assessment and to inform a care plan and to evaluate it. We're also aware that there was no brief person-centered patient-reported outcome measure that reflects the range of outcomes that are relevant for people living with HIV, that it would enable us to drive and evaluate care. So what we're really talking about here is outcome measures that measure things that are actionable and specific, therefore useful to the clinical encounter. And we've also had to think about what's the construct that we aim to measure here. So there are some challenges around whether we want to measure quality of life, which may be more conceptual, or a construct such as symptoms and concerns, which may be more actionable in a clinical encounter. And also, of course, what we aim to do is support the fourth 90, which has been promoted by Jeff Lazarus and his team in the debates around quality of life. And this paper that we published earlier this year around quality of life and patient-reported outcome measures identified that there are some challenges that remain in the collection, interpretation, and use of PROM data for people living with HIV. And we also know that patient involvement in development of PROMs is absolutely key to make sure that they're usable, acceptable, and reflect what matters to our population of interest. And of course, here in the UK, in our standards of care for people living with HIV, we now have a standard of person-centered care. That's what we should be expecting to deliver and receive. And these standards were co-authored by community and clinical colleagues. So I'd like to talk briefly now about the positive outcome study, which is a novel patient-reported outcome measure for people living with HIV, which we've been developing to improve person-centeredness of care, to inform holistic assessment and quality improvement, and to develop a measure that have both a clinical and a research function. The construct that we're measuring with this is clearly symptoms and concerns because we want it to be used in routine practice. And there are a number of papers we've published now on the development and initial validation stages of the positive outcomes, patient-reported outcome measure. And I'd also like to acknowledge all of the colleagues on this slide who have been part of the positive outcomes program of research. Really importantly, we have followed best practice in the development and testing of health outcome measurements. So in addition to the existing guidance on outcome measurement development, we've tried to follow very closely the Rothrock model, which is really enabling us to think carefully about the conceptual development, generation and validation of the measure so that it has optimum chance of being usable in routine practice. So first of all, we wanted to determine the priorities of adults living with HIV in terms of measuring their outcomes of care, to develop the patient-reported outcome measure, and also to determine how it should be best implemented to improve patient-centeredness from the perspective of people living with HIV, their clinicians and commissioners. So this is an observational study in line with the COSMIN taxonomy and guidance, as well as the Rothrock guidance. And again, I would refer you back to our papers that have been published in the last 18 months. So in terms of our methods, we use the COSMIN taxonomy and the Rothrock guidance. We conducted 57 stakeholder interviews, including people living with HIV, healthcare professionals and commissioners. And we determined their primary outcomes, what should we be measuring, the optimal recall period, the length of the measure, what the response levels should be, and the domains of interest. And then we had an expert meeting for item generation, which included people living with HIV, clinicians, academics. And then we've been working on item improvement through 6 cognitive interviews, and we have concluded with 22 items and 1 global item for the measure. So in terms of what we found in this work, well, first of all, patients and participants in the research describe very diverse but interrelated problems and concerns. And there are 6 domains of primarily that they wanted to be included in the PROM. Those were physical concerns, cognitive concerns, psychological concerns, issues around welfare, social needs, and information needs. Also, participants really wanted to have a global item which would assess well-being and free text opportunities to discuss particular issues further. And there's an example on the right, a quote from one of our participants just talking about the interaction between issues like fatigue, education, cognitive challenges, which can really affect the whole sense of self and social participation. So what might be the benefits of using a PROM? Well, for people living with HIV, there was a sense that it would enable patient-centeredness and empower people living with HIV within their healthcare, to help them raise their concerns and to feel heard, to feel valued, and better enable them to share their sensitive information, to build resilience and self-confidence, to encourage referrals, importantly, to reduce assumptions. So making sure you understand really what matters to the patient rather than what you presume matters, helping to get to know patients, and most crucially, moving beyond adherence and viral load as our end concern alone. For services, HIV clinicians felt that it would better enable them to tailor their services and their care to specific populations, to understand how HIV is changing for people living with HIV, to improve efficiency, and to build confidence in clinicians in handling less medical issues, and of course to justify current spending. I think this is an interesting pair of quotes here. The person living with HIV, when we asked them, what would you like to be discussing in your clinical encounters, said, I think in general terms, I would like to hear them say, how is your physical health? How is your weight? How is your mobility? Is there anything going on there? Whereas when we asked the commissioner, which in the UK means those within the health system who are paying for HIV services, who purchase them, said, I'd expect adherence to be discussed in their clinic appointment. I'd expect them to be updated on their latest blood results. I'd expect partner notification. So you can see a real contradiction here between what people living with HIV think should be discussed and what those within the health system paying for health services think should be discussed. So person-centered care now is our goal, and we really believe that the PROM is our way to achieve it, and community have absolutely been at the heart of what we're doing. And here is the measure that we've developed. I'm just sharing the first few questions here, which has open text opportunity first of all, then the overall global item on health and well-being in the last 4 weeks, then questions about information, and then moving on to physical health and well-being. So the first few questions in that are around pain, stomach or bowel problems, memory or concentration, and sleep. The validation of this measure is now complete. I'm delighted to say that 2,251 people living with HIV completed this measure at least once. And that was a large cohort of people living in Brighton and Sussex, in Belgium, in Spain, in Croatia, and in Portugal. And that data will be presented at the Beaver conference here in the UK next month in November. So in conclusion, we know from the evidence from across health conditions that PROMs provide a well-established mechanism to make care more person-centered. If you routinely enable people to discuss what matters to them, you can quickly focus down on their main symptoms and concerns. Selection of a measure is absolutely crucial. You need adequate psychometric properties. That work I showed you around Rothrock and the COSMIN guidance is absolutely crucial. You can't just make up a questionnaire. And particularly face and content validity is important for people living with HIV. Rather than a generic quality of life measure, we need to make sure that we are measuring what matters. Then using the data in a data use cycle is crucial. Completing a PROM on its own will have little value compared to using that data to guide to discussion. And lastly, implementation strategies are absolutely key in PROM successes, and the implementation science of how you empower people to use this and how you can make sure it's routinely adopted and the data is used is absolutely key if we're to really achieve the potential that PROMs offer us. Thank you.